Good morning, everyone. My name is Becky Nelson. I've been a registered nurse for more than 20 years. My entire professional life has been focused on providing direct patient care. I am also the chair of MNA's Governmental Affairs Commission. Today, MNA is releasing a new report entitled Why We Left, which analyzes data from nearly 750 MNA nurses who left bedside care positions over the last 2 years. The results are striking. Over 80% of nurses in this survey indicated that they do not plan to return to the bedside unless conditions improve. The top 2 issues nurses cited, which drove them away from the bedside, were poor management practices and chronic understaffing. Another factor mentioned by many nurses were closures, mergers, and other reductions in service, which pushed nurses out of a job. As far as myself, I first seriously started thinking that I wanted to leave the bedside about 5 years ago. The unit I was working on at the time merged with another as a cost savings measure, and I was forced to learn how to care for a patient population that I was less familiar with and which had a much higher rate of poor outcomes, including patients I've been used to dealing with for the past 10 years or so. The patient deaths and long-term outcomes eventually traumatized me to the point that I was crying in the bathroom at work, crying in the car on the way home. Once I even burst out into tears as I was providing chest compressions to a patient who was in a respiratory arrest. Nurses in this survey shared so many similar stories. One wrote that she left crying after every shift for the last 4 months before she quit. Another wrote that it broke her heart when she felt like she had no choice but to leave her coworkers, her patients, and her hospital behind. I was not given any option by my employer as to whether or not I wanted to continue to work on that unit. I was not told what to expect, and suddenly watching patients suffer and die several times a week was not something that I was emotionally prepared for. When employers treat us as a number on a spreadsheet and say a nurse is a nurse is a nurse, we are left to suffer or leave. I was eventually able to find a new job that was a better fit for me at a different hospital. But even in this position where I love the work that I do, the pandemic has exposed the crisis in our hospitals. In the beginning, we didn't have enough PPE. Employers told us to utilize a PPE standard that was not sufficient, and I was quarantined for a high-risk exposure, a work exposure. Then my colleagues started leaving. It was about working short-staffed. It was about respect for our own health. It was about the employer not listening to us and our needs. We continue to be denied hazard pay or any kind of meaningful bonus or retention plan at my facility. As you'll hear from our panel of nurses today, the effects of the retention and understaffing crisis have hit nurses differently. Some colleagues went back to school, never returned. Some went on maternity leave and never came back. Many that could afford it simply quit or retired early. Many nurses took hours reductions. I have personally applied for a dozen or so non-bedside positions over the last 5 years. The actions of our employers can make or break the will to stay at the bedside. Instead of working to retain us, we're being used up physically and emotionally. We are not a billable line item. We are not robots. We are not heroes. We are not angels. We are highly skilled professionals, and we are people. We need to be treated as such. Nurses are ready to fight and win legislation, like the Keeping Nurses at the Bedside Act, to put patients before profits, retain nurses at the bedside, and prioritize quality patient care in the state of Minnesota. It's my pleasure to introduce the other nurses on our panel today. After our discussion, we'll be glad to take a few questions from the press about this report or our testimony here today. And these are all nurses that have left bedside care positions for a variety of reasons, and they will go through that. So if we could just go down the line, and we'll start with Carrie. If you could share your name, where you worked before you left the bedside, and what you're doing now.
My name is Carrie Marchard, and I am the nurse staffing specialist with the Minnesota Nurses Association. I worked at Abbott Northwestern as a cardiac ICU and cardiac telemetry nurse, and back in 2005. And then I left and came to MA.
My name is Chauncey Bartman. I'm a nurse in the emergency room at North Memorial. I went casual part-time there and accepted a travel
Rachel Hanneman. I was previously at Hennepin Healthcare, and before that I was part of the closure involved with St. Joe's. And I'm currently doing travel as well because of schedule accommodations.
Amy Faulkner, I was at St. John's, M Health, was Health East, Fairview bought us out. I was a nurse for 30 years. I retired on December 27th, something I never, ever thought I would do.
My name is Nick Schillingford. I worked at the University of Minnesota Medical Center on the West Bank with M Health Fairview in their adult float pool, covering a number of units, and I actually left this past September, so September 2021, and currently I am doing a community health position, doing vaccinations in the community, but very casual, and still dealing with anxiety and some of these other things that were really played up last year.
Okay.
And you know, staffing was an issue the entire time that I was working in that position. The pandemic definitely did have a big impact on the staffing piece of the puzzle. And you know, we saw more and more shifts where we didn't have the staff that even our own, you know, staffing matrices said that we needed to have to staff the unit safely. We weren't even meeting our own requirements for the number of staff that we had. So that was a big part of it, was the fact that we didn't have the staff we needed for me to feel that I was able to do my job safely and professionally. But more than that really was, you know, as an individual, and then also as someone who was elected to represent the nurses there, we brought these concerns to our managers, to management, to chief nursing officers and others again and again about the staffing issues. And unfortunately, the response did not have the seriousness that was needed to respond to the concerns that we were continually bringing up. I did begin to get really bad anxiety, panic attacks, really high, like fight or flight anxiety feelings at work, even when the shift wasn't that bad. I did take a leave of absence because I didn't want to leave. I didn't want to leave for good. I was planning to go back, and then just I was not able to fully improve my anxiety, and the thought of going back into the conditions that I came out of that were not safe conditions just took that anxiety level higher again, and so I ended up leaving and going to do this community position that I'm doing now.
Thank you, Nick. Amy, what drove you to leave, and what were your shifts like before you left?
Where to start?
Right.
There's so much, and it says why we left. I escaped, literally escaped. M Health Fairview closing 2 hospitals during the pandemic. Unbelievable. Seriously unbelievable. My shifts were chaotic and chaos. I worked in surgery, surgical nurse. With the merger, with the combining of 3 hospitals into one, our surgical supplies were put 2 floors down. 2 floors. So literally 25,000 steps in a day, running up and down stairs to get my supplies for my patient. It's okay, you have a bleeder. Just wait, surgeon. I'll go get it. I'll go get the supplies. It might take me a while. I have to go 2 floors down. Breaking point really was, I can relate, pulling into that parking lot with a pit in your stomach. You're sick to your stomach, crying all the way home. Our patients deserve better. Minnesotans deserve better. It was nothing but chaos daily. But the breaking point was walking in and seeing patients literally lined up on carts in the hallways, outside of the ER. No staff. It's okay, let me just, expose your gown so I can do a lung assessments on you. You don't mind if I expose you in front of everybody? We deserve better. I had a patient that was in the ER for over 18 hours because we couldn't get them on the surgical schedule. Finally got up to surgery, holding their hand, and I said, I'm sorry, I'm so sorry. We're gonna get you back to the OR, we're gonna take care of you. And he goes, I know it's not your fault. I knew it wasn't my fault, but he wasn't going to get an apology from anybody else. Because all these hospitals care about is profit, not the patient. And now you go to a physician's office, you're timed on how much a physician can spend time with you. That is not care. That is not care. Our patients deserve better. Some patients might take 5 minutes. Yeah, you can do your assessment in 5 minutes. Others take hours, and they deserve your time. So I didn't leave. I escaped, and it broke my heart too. I loved my coworkers. I worked with the best surgeons ever. It was not an easy decision, but I had to do it for myself and for my health.
Thank you, Amy. Rachel, what drove you to leave, and what was it like before you left?
The reason that I had to leave is because I'm a single mom, and my increases, I was having increased demands at home with my children, especially as we were going back and forth between distance learning. They're very young, so they're 3 and 8, and I was having just a horrible time trying to balance being a successful mom with coming home from work with everything that you carry home with your shift, and I wasn't being a very good mom to them. And I figured that my kids only have one mom, but we have a state full of nurses, so I tried to go casual before I left. That way I could call that day, hey, can I come pick up this 3 to 11? Can I come in and do 7 to 11? Can I do what you need? And my manager tried to work with that, but the higher up said that they weren't granting casual status to their nurses. And that was, I was speechless at the time because they talk about how badly they need nurses. They were hiring travelers, and then I was told, no, you can't. We're not going to make that happen for you. And it's still, to me, like, I choose to laugh so that I don't cry about it. But the shifts before I left, I remember having this patient in total traction. So she had her leg, she had a C-spine, and you're supposed to take, I think, 3 to 4 nurses in order to turn that patient to give them their daily cares and just to give them the basic assessment to make sure things were doing well. I didn't have enough of those staff people on my unit to help me do this care and this turn. So that whole weekend that I worked last, she didn't get properly looked over or bathed or cared for because we just didn't have enough people to make that work. Even if I took all of my coworkers off of my unit to make that work, we still didn't have enough people in the room to do this turn. And then there was no one else watching the monitors out there. So we didn't even have enough to provide basic cares. And when you do that, you leave feeling so horrible, so incapable, so defeated. When you know that this whole weekend that patient didn't get what they needed, and they are some of the sickest people in the state. So you feel completely worthless leaving this job. It was one of those things that just made me realize that sticking it out wasn't helping me and it wasn't helping them.
What about you, Chauncey? What were your shifts like before you left, and why did you leave?
Yeah, I'm still finding that balance. Not completely leaving, but I mean, it's hard to explain it. Like, you might have somebody coming in with like a COVID exacerbation, because they have asthma or COPD or something like that, is a struggle, so they have to go on BiPAP immediately, and they're really sick, so there's a number of other therapies that they need real quick. And then you might have somebody right next door that you're caring for as well that comes in with like a GI bleed, and they need a lot of different therapies very quick. And then you might have somebody that you're caring for as well that might be detoxing from alcohol, and they need you in that room every 15 minutes to give them medicine so that they don't have a seizure and possibly die. So, and that's just a 3-bed assignment. Sometimes you might have to flex up to 4, and who knows what that other patient's going to be. But then you're not the only one with that type of assignment. Everybody has that type of assignment, and you get, sometimes, I remember going to work one day and they're like, well, we're 6 nurses short today. It's like, how in an emergency room are we 6 nurses short? So these people, and our patients are suffering, is what it comes down to. They're not getting the therapies they need on time, and they suffer. And then they sit in the ER, and we take care of them like an inpatient for 18 hours, or what have you, before they go to surgery. And that's just not the right setting for them. If we had the staff, it would go a long way to better patient outcomes. And I mean, these are the people that are in your community, your family, your friends, the people that vote for the legislators that should be taking into consideration the Keeping Nurses at the Bedside Act. So, like I said, I'm still working that balance on. I haven't fully left the bedside yet, but it's a struggle.
Carrie?
So I left Abbott Northwestern, and the breaking point for me was the day I came into the cardiac ICU, which is at the time they had 4 beds in 1 suite, and I was working with 2 other nurses that had very sick patients, and so they were assigned 1 patient each, and then I had 2 lesser acute patients, so I had 2, but there were already 4 patients in those beds. After I got a report on one of my patients that was going to be transferring up to the cardiac step-down telemetry unit later on in the day, after I got a report, I went to go get medications, and I got a phone call that I was getting another patient. And as I looked around the room and realized all 4 beds are full with patients, there's literally nowhere physically to put this patient that's coming from the post-anesthesia care unit. And when I said that I already had 2 patients and that we didn't have space, the response was, well, put your open heart patient that's going up to the tele floor in the hallway with a tele pack on in a wheelchair because we're bringing your carotid down. Just a surgical term. This patient was maybe mid-70s, and he had survived a heart attack, and his wife had finally gotten an opportunity to go get some rest. And I knew that my critical piece that morning was to do education and prepare them for going up to the other step-down unit and then eventually to home. Technology and healthcare has advanced so quickly that we are able to save people today that just a few years ago probably would have died. But I don't think we take into consideration the mental, emotional stress that these patients are under. And we also know from public forums that we've done that the most critical piece of a nurse's job with a patient is doing discharge teaching with them so that they know how to care for themselves when they go home. And I bet you can ask any one of these nurses here that when there's a telemetry monitor going off, there's a patient that has fallen, you're late on giving medications, your IV antibiotics haven't been hung yet, you have blood waiting at the station for you to hang, and teaching is on your list, those other things tend to take priority. And then I have literally wheeled people out for discharge, teaching them about their medications as we walk down the hall, because there was no time to do it. Nick talked about the trauma. Amy talked about the efficiency and lack of efficiency. These hospitals hire company after company to come in and tell us how to do our job quicker and faster. At one point they said, instead of counting to 3 when you boost, just count to 2, because that'll save you so much time.
And don't use
Rachel
proper
saying-
body mechanics.
Right?
This is a laugh to keep from crying situation.
I know, and Rachel's saying that my kids only have 1 mom, but there's a pool of nurses. There are a pool of nurses. There are a lot of nurses. I didn't want to leave either. None of us wanted to leave. But I knew for my patient safety, for my license, and for my well-being, I had to do something different.
And you forget with all that going on, that's when they're gonna do a mock fire drill too.
Yeah, exactly.
So, we can just maybe go back the other way if you want to handle this one too, Carrie. Hospital executives often say it's just the fear of the pandemic or burnout, from patient care that is causing nurses to quit. What do you say to that? What's your reaction?
Well, I left in 2005, so it had nothing to do with the pandemic at all. Staffing was bad back then. I left the tele unit thinking, well, if I go to the ICU, right, they're so sick, there's no way I can have a bad assignment. Well, I learned very quickly that it doesn't matter. It's just move them out, move them in, turn them over as if they are patients on a conveyor belt. And just think about about how much time we all have to argue with supervisors and managers every day about trying to get more staff when we could be at the bedside delivering care. It's the nurses that are delivering the care that should be involved with determining what is safe. And there is research out there that says for every single inpatient care unit, what is a safe assignment, and we have been working on this since I left in 2005. This isn't the first time we've been in the legislature, and it's not going to be the last.
I guess I'm up. I have a problem with the term burnout, first of all. Burnout makes people think that there's something wrong with us, and there's nothing wrong with us. I prefer moral injury because we want to take care of our patients. We want to do the best we can by them, but we are not afforded the time or the resources anymore. And so we can't provide the level of care that we know we should to have the best patient outcome. And it hurts us. It morally hurts us. It doesn't burn us out. We could go on doing this, but that moral injury tears us apart inside. And it irks me just to hear burnout and how they use that term. If they want nurses to stay, do things like keeping nurses at the bedside act and have more resources, because if we're not having that moral injury, we're going to stay.
How about you, Rachel? Are you burned out, or are you afraid of the pandemic?
I am not afraid of the pandemic, and I only say that because I spent a literal year in the pandemic hospital, and that to have someone say that nurses are burned out from the pandemic, I would like them to come. I've never actually met someone who's been willing to say that directly, so I'd like to have that conversation with them myself. If there's anyone who's willing to attribute nurse burnout to the pandemic, I'd be more than happy to discuss that with them in person myself. And even saying burnout and moral injury, I feel like places that burden on me. We have been advocating so hard for so long to keep things safe and effective the way they are. Go ahead and sit down, Carol. That hearing anyone say that it's the problem with nurses at the bedside is just so disrespectful. I don't know how to say that in any other terms than that. It's just so disrespectful. And you're blaming the situation that we're in on us. We don't have any power over the situation that we're in, and we are doing everything we can to get us out of it and to get people through it. And so to say, well, you're not doing a good enough job, you're burned out, that's how it makes me feel.
It's hurtful.
It is
frankly.
hurtful and disrespectful.
Yes. And your thoughts on that, Amy?
100% agree. Had absolutely nothing to do with the pandemic. Nothing. It had everything to do with lack of management in my facility. It was, and again, chaos with closing 2 hospitals, combining them into 3 hospitals into one, lack of management, and I couldn't provide the care that I had been giving my patients for 30 years. I want and know how to treat a patient, and I wasn't able to do it, and it killed me. It hurt to leave. It really did.
And what about you, Nick? Is your fear of the pandemic?
Well, I'll
Or
say
what
this.
kind of fear?
I was scared with the pandemic when we weren't getting the protective equipment supplies that we needed. But I'll say I was cross-trained to a biocontainment unit at my hospital, so that was set up after Ebola. It was a volunteer basis thing to help out in crisis situations. And I actually raised in 2019 the concern that all the supplies on that unit were out of date, and that if there was a pandemic, how would we get the supplies that we need for a pandemic that we know is coming? They did not update those supplies, and there was a pandemic that started in 2020, as we're all aware. And, I had to raise that again. They actually didn't reach out to any of the people on the biocontainment unit when the pandemic started in any way. We didn't hear anything from any of those managers, any of those directors. I actually had to reach out to those people specifically because we weren't getting the protective equipment that we needed to do our jobs. Eventually, we did get most of what we needed, and I continued to work on for a long time through the pandemic at that point, so that clearly was not the issue. But There was a lot of parts. You know, I mentioned staffing, different kinds of patients that we weren't necessarily used to dealing with were coming to our unit, and that was happening for a lot of nurses. Patients that they did not have as much training or experience in working with, so they were not, you know, in the position to give the best care to those patients. I was definitely seeing that. You were coming on to shift, and pretty much everything was behind because the last shift didn't have the number of staff that they needed to do the job. So as soon as you get there, I've got 4 patients when I get there. And not only do I have 4 patients, but they want to send me another patient, and all of those patients have cares that have not been completed. And I said, well, I have patients here that have, you know, absolutely important necessary cares that have not been completed. So I won't be taking another patient until we, you know, meet those needs of those patients that I'm already taking care of. You know, so I had to spend, speaking of the very shift where you realized you had to do something. I spent a good chunk of that shift calling managers, calling supervisors, trying to figure out, we need to get the staff here that we need because all of these patients have cares that are behind right now, and they're trying to send additional. I eventually did get 1 additional staff, and then that person was sent a bunch of admits right away, so they were busy the entire time, and we had no backup staff. I played that role too as a resource nurse. I would be a resource for the rest of the hospital. Again and again, those people were either sent somewhere else or not scheduled. We had no resources, so if there was a semi-emergency event where we needed some additional help to make things move smoothly or be more efficient, we didn't have some of those resources that we needed, and that was very scary. So ultimately, it was the staffing, not being able to deliver that quality care that you expect to deliver to your patients that you're going, I live in Minneapolis, this is my community, so I was working with people from my own community, and I expect to be able to deliver them care that's appropriate and, meets the requirements of their condition, symptoms, etc. And they deserve, absolutely. And if I can't, meet that, then I have to do something else, and that is what I've done, and now I'm working in a very casual community position.
Okay. All right, and we can go back
I forgot
the other
what the
way.
last question is.
Yeah, I'll
Okay.
stay it because the press has got to hear too. What would have to change in Minnesota hospitals for you to have stayed at the bedside, and what do you think needs to change to solve understaffing and retention?
We absolutely need staffing ratios, not even anything to do with the pandemic. We absolutely need to have clear ratios of what is appropriate to be able to deliver the care that a patient deserves. But even more than that, I think some clarity that the people that are in charge of public health and of hospitals specifically are listening. Are listening to what's being said by nurses, are respecting nurses' professional opinions, and are taking actions that demonstrate that they believe and have faith in their own professionals that they've hired.
Okay. And what would have made you say, do you think, Amy?
Leadership, competent leaders that are willing to listen and understand. When a nurse tells you that they don't have the supplies or the staff to do the cares, we're not making it up. It is what it is. If I don't have the resources, I don't have the resources. And to have a leader that actually knows the department. My leader that I ended up with never spent a day in the OR, but they were my director. Yeah, that was eye-opening when we're going through all the changes, and she looked at me and she goes, well, we're trying to get the supplies up, but these rooms need to be temperature controlled. Did you know that? Yeah, I've been in the OR for 27 years. I did know that. It's a shame you didn't. So yeah, leaders, that, and definitely ratios. We need staffing ratios, absolutely. And how about you, Rachel?
I would still have the job that I had applied for. I loved the acuity. I loved knowing that I actually helped make a difference in the outcome of some incredibly sick, fragile, vulnerable people. I had someone in my community come up and say thank you for taking care of his brother when he was at St. Joe's. So I know that these outcomes are not just real and they're not just made up messages that they send us. So I liked being able to continue with that impact when I went to Hennepin. But I think what we need, this is just such a broad statement, I think we need to be respected by upper management. When we say we need something, it's not made up. We're not making it up. We're not trying to be needy. We're not being inflexible. I needed a schedule accommodation in order to take care of my family. If we're expected to take care of patients and their family members, why don't we get the same thing in return? We have to look out for ourselves, and we weren't getting that. I think that they need to start seeing us as adults who contribute to their workplace. It sounds like it's not that much, but that's something that I feel like we're lacking. When we say this is something that we need, our response is try counting to 2. That's not what we said.
Chauncey?
Agreed. I think I've said it a couple times now, and I think you boil it down to we do very much need the Keeping the Nurses at the Bedside Act, because for all the things that we've said, there are things in that account for everything that we've talked about here today, and I think it's necessary for moving forward, because there's evidence, like the reason that they put the things in there is there's evidence to show that there's better patient outcomes if we do these things.
Right.
These patient outcomes, this is your mom, this is your dad, this is your brother, this is your family, this is your coworker. These are the community members, these are the people that are voting for you. So if you don't stand with them, then you're kind of complicit in the poorer patient outcomes that could happen if you don't help us like that.
Carrie?
Maximum patient assignment limits. There has to be a max on the number of patients that are assigned to any nurse at any given time so that they have the time they need to deliver care. And it can be adjusted downward based on patient acuity. So if the patients are sicker, that means you have less patients because you have to spend more time to make sure that there aren't near misses and that patients aren't falling through the cracks.
Okay. That was what we have for discussion questions with our panelists. We can take questions from the press now, if there are any.
Hi, I'm Kyle from Carol Evans. Sorry for watching a little late, so this was already covered. Sorry. But I was wondering, since it sounds like you're from various hospitals, is there a hospital system that's known to be the least supportive? Like, is there talk among you all like, oh, I would never work at that one? Or are they all kind of equally just in the same bucket of the complaints here? And then kind of as a follow-up to that, what is this a Minnesota problem, or like is Wisconsin experiencing the same thing? New York, like how does this compare in other states?
I can field some of that, and if other folks have. Sorry, I'm trying to just write down.
That's okay, Becky. I'll answer that. Our other states. There are a lot of other states and nursing organizations that are advocating for maximum patient assignment limits. And this idea that ratios are this taboo thing is such a joke because, as Nick referenced before, he talked about a staffing matrices or a grid. So it's the staffing plan that hospital management builds a budget around every single year. So the nurse manager on the unit will look at the unit, look at the census of the unit over the entire year, the acuity, and then hopefully the level of experience. Because if you've got nurses that are, Amy's wisdom, that there's a little difference way that you can staff. If you have 17 new grads that you hired because that's how many openings you have, you need some experience on the unit, right? Mm-hmm. So every year they will build a budget. And they will determine that if we have full census on our unit at 43 patients, you have to have 17 nurses. And if you do the math, that's a ratio. That's already how we staff. It's just that it only favors them. So the nurses will tell you if they happen to be over the grid, even though the patients are sick, management will start sending people home immediately. And if you're under, it's just a guide.
Yeah.
Do the best you can, cross your fingers. And I can tell you that crossing your fingers is not a defense of the Board of Nursing. I did the best. It doesn't work. You have to justify why you accepted an assignment that was unsafe. Because according to the Nurse Practice Act, nurses are required, ethically, legally responsible to accept only care that they can give that's safe. Yet the system they are working in doesn't allow them to do that. Go ahead, Becky.
With regards to the hospital systems, I would say, you know, just from what I do know a fair amount of nurses that work in many different hospital systems with my role. And I would say, as far as patient care goes and as far as how they treat the nurses, they're all approximately the same. I wouldn't say that any is any better than any other. They all kind of operate by the same not for profit, but actually for-profit model. There are a few small differences with regards to compensation. There are a couple hospitals that are giving a little bit better bonuses and that kind of thing, but overall, the patients, you know, the patient care is the same. Yeah. Did you answer the last of
I don't think anyone out
it?
here is going to tell you who's the worst.
Yeah.
Nurses take great pride in their hospitals.
Right.
We have talked over and over again on how we can try to get the message out. And you know, nurses we don't like to scare the public. We don't want to tell people that things are unsafe, but at some point we don't have a choice. Because when patients come in, I think they feel like once they get in that building, nothing bad's going to happen because they're in the hospital, right? And every one of us can tell you stories of where someone didn't get the care that they needed and something bad happened. But if it doesn't rise to the level of the definition of an adverse event, then it doesn't seem to matter. And it matters to each one of us.
Any other questions?
I was just curious, you know, we're looking at the last 2 years, this number of 748. You all said, you know, the top reasons being that nurses have left. I think it was management concerns and staffing. But we've heard from nurses over the last 2 years talking about that the pandemic was tiring, that it was. Can you clarify that a little bit? Because what I'm hearing is that it wasn't a reason at all, but maybe that's not what you're saying.
I can talk to you a little bit about that. It wasn't the reason I left, but it was tiring. You know, you have citizens that complained about wearing a mask into the grocery store. We all have worked 8, 10, 12, surgical 24. When I take call, 24 hours wearing a mask. So it was tiring. And then the different protocols going into it. Okay, I have to wear my N95 mask. But now, today, you know, I can reuse it. Use it one and done. But, nope. Now I can use it all day, every day for 5 days. Then I can, you know, carrying it around in my little brown bag. So it mattered, but it wasn't the main reason.
As far as, you know, my opinion on that, and I am one of those people that did have some stress from the pandemic. I have an immunocompromised husband at home that I didn't want to bring COVID home to. It really just laid bare the everyday issues that we already had at our job, because every patient in the hospital had to be assessed for their COVID status. We either, you know, didn't know, or we didn't know if they had symptoms, or they came in with symptoms. We didn't know if they had were tested or not, so we tested them at the hospital in the beginning. You know, it was like a week until we got a COVID test back. We didn't have PPE to protect us. The guidelines that we had were poor. We all knew, you know, right from the beginning that it was transmitted by aerosolization, and no one wanted to admit that, and we weren't given the proper equipment. And all of this was on top of the rest of our already stressful jobs. We were every day walking into a building that nobody else wanted to go into. It was full of COVID, potentially in the walkway going in the elevators. you know, you just could have encountered it essentially anywhere. And, you know, on top of doing, you know, a very hands-on, stressful job where you really have to be present for your patients, it just was kind of it was a breaking point for some people. A lot of us have survived the pandemic with grace and did very well. You know, this is what we were built for in some ways, but it did lay bare the fact that management didn't support us in a lot of ways.
I think what Becky and Amy are getting at is that those pressures of the pandemic wore people down to the point where they couldn't pick up the extra shifts you used to, right? And so depending on where you are in your life, if it's your own wedding, your child's wedding you're saving money for, you might pick up, I'm going to pick up an extra weekend, I'm going to do a double here, I'm going to do this to get some extra money. But then with the pandemic, nurses were like, no amount of money. I can't do another shift. I can't go beyond. And so we knew staffing was a problem before, but nurses were fixing the problem over and over and over and over again. And this just exposed that they can't do it anymore.
Which got pizza party.
Yeah.
I would agree because they were offering double critical shift bonuses. It's like, no, like you said, if I stay, they're never going to fix the problem.
I think nursing was already a fragile almost profession where we were looking at it before the pandemic and asking on the floor. I remember a few times asking our unit, like, yeah, but if we weren't nurses, what would we be doing instead? Because there are a lot of people were like, can I do this forever? I don't know if I can. And so we would kind of just jokingly talk about that. And then we decided to stick the pandemic out. And now I think that was just what broke the camel's back. It's like, okay, we did it. We have definitely done our part. We've done our time. Nobody signed up for a pandemic, but we did it anyway. Enough is enough.
Yeah, sorry, I'm Max Sestrap from Minnesota Reformer. So, just to underline this point, you're saying there's enough RNs in the state, and the money is there to hire them, but it's a management choice that hospitals are short-staffed with nurses.
I was just going to say, so you know, again and again, we raised, as I would say, I as an individual and other nurses raised together the concern with staffing. And during that time, not only did they not get us often to the staffing that we needed to run those units, they actually changed some of the grids and revised the numbers of staff down in some areas where they wanted less nurses at certain times for the same number of patients. So instead of, say, 5 patients now, at some times you might have 6 patients or something like that as a nurse. And to compensate for that, they put up the number of nursing assistants you would have on the unit, but they also told us they weren't even able to staff the number of nursing assistants that we needed now on the unit for some reason that they did not inform us of what that was. So we asked specifically on those grids, if there are certain reasons that the unit is more difficult or it's more acute, can we have some language in there that the charge nurse who's in charge of that unit can, you know, get additional staff? They said absolutely not. That is not going to go on the grid. They said the reason was because we want those charge nurses to be able to be creative and use their critical thinking when they're scheduling and making staff assignments. So they didn't want to, their reasoning was that they wanted to supposedly leave control with the charge nurse. But again, really, it was just a reason to not staff the units appropriately and to continue to push nurses to take on more patients above and beyond what's safe. At least that was my experience.
We're seeing lots of efforts to recruit more nurses. You know, Governor Walz has rolled out this program to train, you know, hundreds of more nurses, LPNs, I should say. And then, so I guess just maybe if you help me understand that, is recruitment still an issue, or you're really saying that there's enough RNs in the state?
Well, I mean, we made multiple suggestions for recruitment, including, you know, bonuses, helping cover some of the costs of education and licensure. These were made, again, I made these directly to my direct manager, and she raised those concerns above her. And then a month later, when I talked to that manager above her about those concerns, She claimed it was the first she'd ever heard of those ideas. She was going to bring those ideas back. She would share those ideas with other people, but this was the first she was ever hearing of it. And, and I told her, well, I understood that this was brought up last month. Well, it's something we're still, it's still getting talked about. That was the answer every time. Oh, it's still getting discussed. We're still having some meetings about that. We're still doing it. It's like, no, this is an emergency right now.
Yeah.
They told us they didn't know when they were short-staffed, even though they know the required number of nurses, and whether they had that required number or not, they have all that information. And we said, so how do you not know when you're short-staffed? And they're like, well, if there wasn't a problem, then we assumed everything was fine. And so it's really a management attitude that comes down to cost saving and
Or lack
revenue
of
generation.
management.
Yeah, that too.
Lack of management.
Yeah, there was people, I worked with a lot of the other nurses, there was people that didn't even know who their manager was. Because the manager had left, they had put in an interim manager, and then that manager had been transferred to do something else, so they were never actually on that unit. So they didn't even know who they were supposed to be reporting their concerns to.
And when it comes to retainment, when I handed in my resignation letter, I asked for an exit interview. Nothing.
They don't wanna do
Complete
Yeah, I didn't get
silence.
anything either.
They didn't want to hear anything. Nothing. 30 years as a nurse. 30.
So our
in Edinburgh.
workforce report actually does address this directly if you want to grab one on your way out. You have it. Okay, it's on page 3. It's in the background. So there's not a shortage of nurses in the state of Minnesota. That is a misconception. We have churned out 14,000 nurses in the last 3 years. We have 120,000 nurses, registered nurses that are licensed in the state of Minnesota. That's the highest ever number that we've ever had. The shortage comes when the nurses that we have in the state don't want to work in a hospital under those conditions. Many are unemployed. Many have cut their hours. I think you've heard the stories from all of us here. It's not that we don't have enough. It's the fact that they won't work in a hospital like this. Part of the issue too is just a small issue is the hospitals want to staff shift by shift. Sometimes they call it just-in-time staffing. Sometimes they'll even want to staff every 4 hours. What employee do you know, besides in healthcare, in a benefited job that relies on their hours, can work for 4 hours and then be sent home for the rest of their shift, and they have to use their PTO or something like that, or what? It's not. We aren't treated with the same level of respect with regards to our schedules as a lot of other employees in many different kinds of jobs, and I think Rachel can attest to that. They're just not flexible. They want us to work on their terms when they want us, with no regards for us as people, as parents, as citizens, as healthcare consumers ourselves. It just doesn't matter. We are a line item in their budget.
One follow-up, if that's okay. Amy, you just mentioned a story about how they put the supplies 2 floors down and you had to run, so that was obviously
Literally,
poor
run 2
management
floors.
decision.
Absolutely poor
That doesn't make any
management.
sense,
No, it doesn't. And not, most surgical suites, and surgery is kind of like the airport. It's its own little world, okay? And it is the #1 moneymaker of the hospital, even more than your ICUs. And most have like a core area for their supplies. Well, with the combination of the hospitals, our supplies went 2 floors down. You think that they would have one designated elevator for us to go down and get our supplies? Nope. So it literally was easier and faster to run 2 floors down than sit there and wait for an elevator, because you have patients on there that are going to their various appointments, x-ray, radio, wherever they need it to be.
Amy, can you also talk about then you're breaking sterilization by leaving, right? So you're potentially exposing having to leave the OR?
Correct.
So did you have to scrub in and out every time you went and got supplies?
If I was at the bedside, literally handing the instruments to the surgeon, I would have to break, scrub, and run down. and my main job was circulating, so, but I'm leaving my patient, and that's why I left. I am not given the care that my patient deserves. You all deserve that circulator in that room, because that circulator is the one that's looking for sterile technique to make sure that there is no sterility breaks, that if an instrument falls, that you have to retrieve it. I'm running 2 floors down, leaving an intubated patient on that table. Broke my heart. It was chaos.
So what did management say? What was their
And then,
explanation?
you know, these rooms need to be temperature controlled. Yeah, I do. I sat there. I was an M&A chair, and I sat through 1,500 nurses going through the rebid. We asked them what their plan was when they were combining all the hospitals. Oh, we'll be fine. We'll be fine. We weren't. We weren't fine. Who puts their supplies that desperately needed in the surgery suite 2 floors down? It was chaos, literally chaos. And I couldn't do it. I couldn't give the patients the care that they deserve it. They deserve. And that's why I had to leave, because they deserve better. We all deserve better.